Frontalis sling surgery is used for ptosis correction with minimal levator function. The fascia lata harvest is reviewed in detail in another video on this website. We will therefore only review it briefly here. Fascia lata is generally harvested along a line from the head of the fibula to the anterior superior iliac spine, starting at least 10 cm above the femoral condyle. The knee is flexed to 90 degrees and the hip adducted or internally rotated to about 15 degrees. This position tightens the fascia and improves access to the lateral thigh. The skin and superficial fascia are incised. The incision is approximately 3 or 4 centimeters long. A thick layer of overlying fat is easily dissected off the fascia, which is seen underneath as a tough white layer. The superficial layer of the fascia lata contains horizontal fibers. These can be picked off the deeper longitudinal fibers with forceps, or firmly scraped away with a gauze. In this operation, a Fox pentagon brow suspension is planned, which will require approximately 12 centimeters of fascia lata. The required strip of fascia lata must be freed up as far as possible, and ideally the full 12 centimeters on both anterior and posterior surfaces and down each side, with long scissors such as the Mayo scissors being used here. The inferior end of the strip is cut with scissors. A suture can be placed at this end in order to relocate the strip if it is lost during stripping. A fascia lata stripper is used to release the fascia lata at the superior end. This video shows the Moseley or Masson fascia lata stripper, but other designs exist, or harvest can be done without a fasciotome. The stripper is slid along the fascia lata strip, again ensuring that the line marked on the overlying skin is followed. When the desired length has been reached, the blade of the stripper is closed in one swift motion to transect the strip. The released strip will be divided into smaller strips of 2 to 3 millimeters width. To do this, the surface is dried. A small cut is made parallel to the fibers. The strip can then be torn and will follow the longitudinal fibers. The strips must be then moistened again and kept moist until they are used. The fascia lata is carefully closed in order to minimize the risk of muscle herniation. An absorbable suture, such as monocryl foro, or a permanent suture such as Prolene foro, can be used. The fascia is closed as far superiorly as can be accessed. Deep sutures close the superficial fascia. A subcuticular suture is used for the skin. Fascia lata harvest is not without complications. In the short term, many patients will have a limp and/or thigh pain. This usually settles within a week. Hematoma and infection can also occur. Loss of cutaneous sensation can occur if the lateral cutaneous nerve of the thigh or its branches are damaged. Muscle herniation can occur through the deficient fascia. The rate of muscle herniation is not well reported, but this probably occurs more commonly than we expect and will likely require the assistance of a general surgeon to repair it. Several sling designs have been described for improving ptosis. The Fox pentagon design is demonstrated in this video. 2 stab incisions are made in the upper lid, one lateral and one medial. 3 further stab incisions are made in the brow, one just lateral to a line drawn vertically from the lateral canthus, one just medial to a line drawn vertically from the medial canthus, and one central or slightly medial of central. When making the medial incision, check and avoid the neurovascular bundle running superiorly from the supraorbital notch. The fascia lata strip is fed around the pentagon with the right fascia needle. The use of a corneal guard is advisable. When passing the needle from the brow incision to the lid incision, the sub-brow upper lid skin is picked up with forceps to ensure that the fascia will pass reasonably deep in the upper lid and brow in the post-septal plane. Numerous other sling materials have been described. Autologous fascia lata is sometimes described as the gold standard, because it is extremely unlikely to be extruded, has a very low likelihood of infection, and is thought to last longer than the synthetic materials. However, it does require a second surgical site to harvest the graft, with the associated additional morbidity and complication risk, and, unlike silicone and other synthetic materials, is not easily adjustable. Other videos on this website demonstrate the use of silicone slings. There are several variations to this technique. For example, if a small blepharoplasty is desired, the tarsal plate can be exposed and the fascia lata strip sutured to the tarsal plate in 2 or 3 locations. The 2 ends of the fascia lata are tied off in a knot. A pocket is created subdermally at the central brow incision to accommodate the knot. Post-operatively, if the lid is too high and the cornea suffering damage from exposure, the knot can be identified and loosened, although it is certainly much easier to do this in the very early post-operative period, unlike a silicone sling, which can be done much later post-operatively. A suture is used to secure the knot to the subcutaneous tissue to try to avoid it slipping. This suture may not be necessary, as the fascia lata tends to stay quite stable. The small brow incisions are closed with a single suture.